Okay, so next up, now that we have our background into the physiological effects of cold, we're going to talk about using cryotherapy during immediate care. So when we think about immediate treatment, again, you got to think about within the inflammatory response. So typically the first 24, 48, 72 hours that we discussed when we talked about the inflammatory response phase. So usually our main focus during that entire time is either RICE or PRICE or RICES or police or whatever acronym you want to go with. Because again, our goal is to limit the extent of the injury in order to then allow and facilitate healing and the rest of the steps of the inflammatory response cycle. So most of our treatments are based around, again, this idea of RICE. So rest limits the scope of the original injury by preventing further damage. We talked about how that needs to be relative rest. But again, thinking in short term, we're talking within the first day to 2 days, maybe up to 3 days, that we're really trying to rest and support that area and provide stabilization. The ice, which is where we're going to focus most of our conversation in this video, is going to be there to help decrease cell metabolism in order to help reduce the need for oxygen. That whole idea of trying to decrease secondary cell deaths so that we can do very little for the injury that already happened. Those cells are dead. They're going to be repaired through the normal process that we discussed. But we can set up a situation where further injury doesn't occur by healthy cells being affected by the lack of oxygen that is kind of a byproduct of the rest of that inflammatory response cycle. Compression decreases the pressure gradient between blood vessels and tissues. So again, helps to remove those side effects of the inflammatory response cycle, the blood and hemodynamic changes that occur that end up forcing more fluid out of the capillaries and into the tissue. Compression helps counter some of that, as does elevation, so using the force of gravity to help encourage venous and lymphatic return. So when we are talking about cold application during immediate care, so again, keep that in mind. We're talking initially after an injury where our goal is to decrease that secondary cell death. We have a couple options that occur for cold application. By far the most common is using some sort of cryotherapy pack or ice pack. Depending on your goals. So the most common and actually the most effective is using crushed ice. Anytime we use actual ice, we get that added benefit of the fact that the ice goes through a phase change we talked about in the last video. So it goes from a solid to a liquid, which absorbs more energy from the body, thus leaving the tissue cooler during that time frame. So because it goes through the phase change, it's going to extract more heat. It also stays relatively cold longer, especially depending on the size. You can really customize the size of the modality that you make, the bag that you make, to the injured body part. And unless it's applied for hours and reapplied and continuing to refresh, there's not really a risk of frostbite. Again, because that temperature gradient is going to hover and kind of even itself out, as long as we don't continue to over apply ice in using true crushed ice, we're not going to have risk of frostbite. Now, the other good thing about the crushed ice versus the cubed ice is that cubed doesn't conform to the body. So the crushed or the pellet ice allows you to form it to the body, which increases our surface area and also takes away a lot of the chance for air, which air is going to act as the insulator. And if we remember back to our heat transfer equation, that's going to increase the K. It's also going to affect the distance, that change of length. And so we don't want air to be used as an insulator. So the crushed ice allows us to do that. One note on using true ice, which is going to be our recommendation. Don't ever refreeze a pack. So if you put ice on, or I should say your patient most likely, instruct them not to do this. So if you put ice on for a little bit and it starts to melt, and then don't just throw it back in the freezer and expect it to work again. Okay, when you refreeze something, the surface of that then becomes at about 1 degree Fahrenheit, which is much lower than our 30 to 32 degrees Fahrenheit that we have typically for our crushed ice. And so then we have a risk of frostbite because that surface gets so much colder. It also solidifies, which means that then we can't form it to the body like we did with the crushed ice. So looking at some other options, we have gel packs, or what's kind of referred to as artificial ice. And these are the reusable packs. So they have a combination of antifreeze, water, and a gel-like silicone substance that is then something that can freeze and refreeze without solidifying. The issue with the gel packs and the artificial ice is just that there's a nylon cover that you put over compared to just the gel pack. They're nice because they're reusable, so they're convenient for patients, but they don't go through a phase change, so we don't remove as much cold. They don't stay as cold as long as regular ice does. And when they freeze, again, we have that same issue that they're kept at 1 degree Fahrenheit. And so we have more concern about direct contact to the skin. Now the artificial ice that has that nylon cover, you put that on after, and so that keeps the surface at about 32. But you need some sort of barrier. And ideally, we mentioned when we were talking about what affects our heat is ideally we want to go skin to skin. And we can't really do that with the gel packs because of that risk of frostbite. Then finally, we have the crushable chemical packs. So these are those first aid staples that are in first aid kits that have a chemical that when you crush it together, the chemicals mix and it creates an endothermic reaction, meaning it's pulling heat and so it feels cold. It's never cold enough. Okay, so when it forms, it doesn't get cold enough, and that cold does not last long enough for us to actually pull out the heat needed to get to deeper tissues and to get any of the effects that we're going for, the decreased metabolic rate or anything like that. Plus they're dangerous chemicals, and so you need a layer between, which is going to decrease our effectiveness. Plus we need to be careful that it's not leaking and things like that. So not recommended for emergency care. You know, last case scenario that you just need something on for about 2 minutes while you run and get an actual ice pack or something like that, then maybe, but it doesn't do what our focus will be for immediate care. And then we have the things that, you know, are less common but need to be talked about. So frozen peas, a steak, all those things you've heard of to like put on an injury. The frozen peas actually is not a horrible option. It's actually probably similar, if not a little bit better than the gel pack because it's formed. You can kind of form the peas. Now you can't get those peas that you've left in your fridge too long and are rock hard and solid. You need a fresh pack of that. But it's definitely less than the crushed ice. There's no phase change. It doesn't hold its cold as long as the crushed ice would. So again, an option, but it's not going to get us at our best results. Ice water immersion and ice massage are both things we're going to talk about for post immediate care. We don't use them immediate care wise because immersion, you have to be in a gravity dependent position. And for all of the other ones of these, we'd want to be elevating while we also do the treatment so that we can help assist that venous return. And so you can't do that when you're trying to stick someone's foot down into a bucket. Ice massage, we don't leave on long enough. Because of the pressure of actually doing the massage, that can be painful to a fresh injury, so it's not recommended either. So again, in our immediate care, what are we doing? So crushed ice packs are applied directly to the patient's skin. The exception being if you're using any of those artificial ice or gel packs. Don't put those directly to the skin, but again, they're not going to be as beneficial. Even using crushed ice not directly to the skin is not going to be as beneficial as going directly to the skin. Our length of application, if we're talking about immediate care, we're talking at least 30 minutes. Okay, sometimes we say 20, we should really be at 30, and you should really then also look at that adipose tissue and actually taking the skin fold measurements to really determine. But we can go from 30 minutes up to 60 minutes. And so again, if it's a big adipose area, we might need to be at 60 minutes. If it's subacute, if we're going to talk about our post-immediate care that we'll get to in the next video, then we really use it just until numb, just until that pain relief is felt. Flesher, deeper areas are going to need more time than bony. That comes down to that adipose tissue layer. And anything less than 60 minutes, you don't have that risk of frostbite, especially again when we're using our crushed ice. Now this is also taking into account our contraindications, right? So if someone has a vasospastic disorder or cold hypersensitivity, these things don't apply. We would have to be much more cautious with some of those things. In addition, we want to use an intermittent application. And what this means is that we're going to put the cold on, we're going to remove it, and then reapply it. And the goal being, again, during our immediate care, is we want to keep the oxygen demands as low as possible. Okay, so we need to keep the tissue chilled essentially through the beginning stages of the inflammatory response cycle. So again, 24 hours or so. If the person is inactive, if they're truly resting and elevating and not walking around campus or going to their dorm or doing other things, the area can be kept cold by applying an ice pack for about 30 to 45 minutes every 2 hours. If they have to be active, meaning walking to class, or even if that's crutching, anytime they're going to be in a dependent position and be more active, then ideally it's 30 minutes on and 60 minutes off to try to keep that temperature down. Okay. For coverage of that, okay, there's some benefits to, and some people have talked about using a wet or a frozen ice wrap to help draw in more cold. Your book talks a little bit about that as well. For the most part, the research I found and what I really subscribe to is just go directly to the skin. We'll use an ice wrap for compression, but we'll do it on the outside of the ice wrap, or outside of the ice bag, not underneath. Because we don't want to increase that distance, even with something that's wet or already frozen. Plus, if we freeze something, we're potentially increasing that risk of it being too cold. Also remember that the benefits continue after we remove, especially in the deeper tissue. It's going to continue to cool, which is why we can get away with that every 2 hours if they're inactive, or every hour if they're more active. So how long should we be doing this? 12 to 72 hours. Again, we don't love rules of thumb as far as times go. We want to use our signs of inflammation to tell us that we're starting to move out of the inflammatory response phase. So the big question is until the tendency for swelling has passed. And that's obviously going to depend on the severity. So until the time that if they change positions, or if they're in a more dependent position or slightly more active, they don't have this tendency to continue to swell. That would be, and new swelling, creating new swelling throughout, that would be a sign that we're able to start cutting back on our icing and use ice more as a pain control or as a transition to our subacute and facilitating rehabilitation, which is what we call cryokinetics. So again, compression is definitely a piece of doing a really good immediate care, and it should go hand in hand with ice, along with elevation. Devices we can use, elastic wraps are by far the favorite, best option, right? Using a good old ice wrap. So stretch it to about 75% of its capacity, do your nice funnel technique, but do it over the top of the ice bag. A well-made crushed ice bag with very little air in it will hold its shape, and the compression is actually usually helpful in that it also slows the blood flow. And so the cold stays in the area, so it cools the area more effectively versus when you're just icing and your blood vessels are able to pull in more warm blood to the area. So that's really helpful there. There's also cryo cuffs, which your book talks about when it talks about cold compression. And these are actually sleeves, kind of like our game ready sleeves, but they just pump in cold air or cold water. It doesn't pump it in and pump it out, what we call intermittent compression, and we use gravity. So usually it's a cooler that you fill with ice and fill with water, and then you set it in a high space and let gravity pull it through, pull the cold water through a tube and go into this sleeve around the area. It provides circumferential compression, kind of compression all around through the sleeve, but it's not as much compression as an elastic wrap. and it doesn't get as cold as ice with an elastic wrap. And so it doesn't really help us keep the temperature down in the tissue as much as we would want. Flexi wrap. I have a huge pet peeve with flexi wrap, mainly because it encourages what we just talked about not encouraging, which is to be active during your icing as well as in between your icing. So when we wrap an ice bag on just with flexi wrap, we're really encouraging them to go walk to class or walk to the calf, and the ice bag falls off, and you're rewarming the tissue. You're activating. So think of putting it on your ankle. You're activating those muscles, which is going to cause heat to be created by cellular activity, which is counteracting all the icing you're doing. So flexi wrap does not provide as much compression as elastic wrap as well, and you'll actually do a little exercise on that on your own, so don't take my word for it. You'll probably feel it. But it really does encourage things that we don't want to be encouraging. So elastic wraps over ice doesn't compromise the compression. It's the best plan for immediate care. It encourages them to elevate and to rest, and it gets us our compression and our cold. So just a reminder again to our general indications and contraindications. When we're talking immediate care, we're talking about this indication right here, our acute injury or inflammation. Okay, so again, within that first 12, 24, 48, 72 hours, somewhere in there. All these contraindications still have to be asked about and seen. If we have issues with these, if someone has that, we do. So if someone has some of these contraindications, we do not want to have to use ice on them. And that can be difficult because it's our go-to in this immediate care situation. But we need to figure out different ways to help with pain and help with the inflammatory response cycle if someone has some of these contraindications. So again, thinking about our evidence-based practice projects, we're taking kind of the best case scenario of just looking at the condition, but taking the patient into account and what other conditions the patient is suffering from is super important when you're making these decisions. So here's our application to do RICEs or RICE, right? Rest, ice, compression, elevation, stabilization, if you will, okay? We want to, our goals, right? Minimize the aggravating effects of the injury, so decreasing the side effects of inflammation. Cool the tissue in order to decrease oxygen demands so that the tissue can withstand this period of hypoxia. Contain the edema and increase the cooling effect. So again, we're not going to be able to stop the edema formation that's happening from the injury, the initial injury. Our goal is to reduce the total amount of swelling that could occur by decreasing that secondary cell death. Lessen the increase in capillary filtration process. That's going to be through our compression and through our elevation. And we can also reduce muscle guarding. If we stabilize and rest the area, it's much less likely that we're going to get into that adaptation, Stain's spinal adaptation theory, where we have that arthrogenic inhibition where we can't control the muscles. So if we rest and support that, that happens. Advantages, it's good, right? We're trying to lessen the total tissue damage. Disadvantages, there really aren't many. There's some debates and some studies coming out about why we shouldn't use ice and we're overusing ice. If you really read those, almost none of them talk about that immediate care and this immediate care factor. So there's very few disadvantages to this. Indications, acute orthopedic or acute soft tissue injuries. Our contraindications, besides those ones that we showed on the screen, okay? These are, again, some additional ones. We don't want the cold on for more than an hour. If it's something that gets stored in a freezer, it shouldn't go directly on the skin. If we're doing a gel pack, we don't want compression over that because that will increase that amount of cold and that surface contact, and that could be bad. Again, some of our cold hypersensitivity, our Raynaud's disease, cardiac disorders, compromised local circulation, decreased sensation, all of those things that you need to study for your contraindications. Precautions, you don't want to wait too long. We want to start this process as soon as possible so we save as many cells as we possibly can. Watch out for unyielding compression. We want something that gives with the person. We don't want over compression that we actually cut off circulation. We especially want to be careful over nerves, okay, superficial nerves. The perineal nerve and the ulnar nerve are super in danger of this, that when we combine compression with the cold, we get issues. Again, those with certain conditions. It can cause hives or an allergic reaction if needed. So you need to watch for that. So pre-application steps, again, thinking about your competency, these are the things you're going to go through. You want to, if it's an emergency situation, right, rule out life-threatening emergencies first and then make your proper diagnosis. Okay, match your goals. Check your contraindications, prepare the patient psychologically. Okay, explain the procedure, what you're going to do. You'll want to go through those 4 sensations of cold. They're going to feel those, right? The cold, the burning, the aching, and then the numbness. Prepare the patient physically, so expose the skin. We want to ice bag directly to the skin. Get in a situation where we can elevate it. Prepare the equipment, so make an ice bag to fit that area. You don't want it overly large, but you also don't want it too small. You want to get rid of all the air. Choose an elastic wrap that will fit but won't create unyielding compression. If we're going to support this area and protect it, maybe it's something that they should be in a sling or crutches or some sort of brace for the next day, just to give that support as well whenever they aren't icing and elevating and compressing. So application, we're going to put the ice directly over the skin and contour it to the body part. Secure it with the ice wrap, do your nice funnel. Check every 5 minutes, at least in the beginning, for capillary refill. Every once in a while, go in and shake the bag. So as the ice starts to melt, a little warmth bubble is going to create right at the skin level. And we want to disturb that because we want to keep the cold closest to the skin so it'll draw more heat out. So you want to shake the bag every once in a while. When we're done, or to support the area as well, you can put a splint or a brace on while we're doing it. Elevate it. Do about, this says 20 to 60 minutes of cold. I would say at least 30 up to 60, depending on your depth of your adipose tissue. Continuous elevation, compression, rest, and stabilization, even when not being cold, okay, when we're not applying the ice. Ideally, we get this on within about 10 minutes of the injury, and then we reapply every 60 minutes to every 2 hours, I would say. So that's at 30. That's probably pushing it a little bit. But again, if they have to be active, we'd want that at least down to 60. If they can be completely inactive, we can go about every 2 hours. And do it every 2 hours if inactive until bed. They don't have to wake themselves up to do it overnight, but at least as much as possible, we want to do this. If it's a first-degree injury, we usually look at about 40 to 45 minutes, kind of, you know, the first hour or so of doing this. And then for second or third degree injuries, you want to do it for at least 12 to 24 hours of this reapplication kind of thing. So post-application steps, we clean up, we check the area for any redness or hives or anything else. We give our instructions, right? We ask them a pre-note, right? We should have gotten our global rate of change or a pain scale before. We should get that after, schedule treatment again. Give them their list of when they should ice and how long they should ice and what is their process. Show them how to do that at home, document everything. And then maintenance, we just want to always check on our ice machines, check on the wraps, check our crutches and braces, make sure everything's in good working order.